I have to admit that we all get excited, we all did clinical trials, we're all culprits here involved in many treatments and many clinical trials, the last of which is a very important trial which was reported at ASCO GI, which we call CALGB 80802, which was based on randomized data of doxorubicin plus sorafenib versus doxorubicin plus placebo. At that time, there was an improvement in survival noted in regard to the doxorubicin sorafenib that led to a randomized large phase 3 trial, which was the first NCI-sponsored phase 3 trial in HCC of doxorubicin plus sorafenib versus sorafenib. Unfortunately, that data did not reveal any improvement in survival. Quite a bit of disappointment for really a very academic, well-regimented exercise moving from a phase 1 to a phase 2 to a randomized phase 2 to a randomized phase 3 that didn't really give us any hope in regard to the addition of doxorubicin in that setting. However, with this said, obviously the future is in front of us, and there's a lot going on, not necessarily in the treatment of the HCC per se, but even supportive therapy. And with this said, I would like to start by discussing what's new and what's emerging in regard to the treatment of hepatitis C. And Amit, please tell us.
Yeah, so I think it's been an exciting time because, you know, I think the new hepatitis C treatments that we've seen come out is probably one of the greatest breakthroughs that we have in medicine over the last 10 to 20 years. We have a virus that we can essentially cure with 95 to 100% effectiveness. And this is not only seen in the large trials that have come out, but also the clinical experience that we see as we treat patients. And these medications are expensive, but highly, highly effective. And when we treat the hepatitis C and cure the hepatitis C, we see a significant reduction both in the liver-related mortality as well as the risk of HCC. So in patients who do not already have cirrhosis, you can essentially almost universally prevent the progression to cirrhosis and prevent HCC. In those who have already developed cirrhosis, you have about a 75% reduction in the risk of developing future HCC, as well as liver-related mortality. So you can have a substantial benefit in reducing future HCC burden.
That's incredible. If anything, we just heard about probably one of the most important achievements in medicine in the last several years, which is that you can cure HCV, by applying the antiviral therapy that we just heard about. And in addition to that, we can definitely even consider a potential cure in patients with cirrhosis already on board. My question is, however, can you give that therapy for a patient already established HCC?
Yeah, and that's what I was going to add, is that I think that this is important not only for people who have not developed HCC, but also as prevention for those who have been treated for HCC. Now, in our practice, what we are doing is we are using this after curative therapy.
After curative therapy, that's very critical. Let's talk about that. Yeah.
So we are treating some people while they are on the transplant list, and if they are not eligible to be treated while on the transplant list, you know, decompensated liver disease, et cetera, that will not allow them to be treated safely, then we will treat them post-transplant. Similarly, anyone who's been resected or undergone ablation with complete response, we wait about 3 months after the therapy, and then we'll initiate them on hepatitis C therapy. Once again, given the data that shows that you significantly reduce the risk of future HCC developing. You can get a similar response for somebody who has chronic hepatitis B related HCC. Once again, it's important to also treat the underlying liver disease as it's been associated with a reduction in HCC recurrence.
Fair enough. Richard, I'm sure you're getting that question in clinic. Patients who already have metastatic HCC, are you giving them, or would you recommend, or what do you discuss with your hepatologist regarding the treatment of the hepatitis C?
You know, I think it depends how they're doing. You know, we've had patients who have had advanced disease that seem to be doing well over months to a year, and I think at that point it's a discussion you can have with the hepatologist. The question is still unanswered, is if you treat their hepatitis C, are they going to live longer? But at some time you just give the patient the benefit of the doubt.
Yeah, I might kind of have a little bit of a more careful opinion on that, but nonetheless, this is a great discussion, which is we really don't know. If anything, the right treatment or the right clinical trial should be joining the protease inhibitors plus a sorafenib, for example, in patients with advanced HCC and see what the outcome might be. Because remember that these therapies might have certain toxicities and as such might actually injure the liver. And that's why we got to be very, very careful in regard to that. And at least I will give credit to my colleague here, Richard Finn, that maybe it's a discussion that needs to be ensured and make sure that we are approaching it in the correct way. Last word on that from Amit.
I think the key thing to keep in mind is when you're looking at this from a population standpoint is the cost.
correct.
These medications are highly effective, but unfortunately also very expensive.
Correct.
So these medications are on the order of about $50,000 to $70,000 per treatment. And so when you look at people who may not have a survival benefit, then you're going to be spending a lot of money to do very little benefit. And so I think that traditionally the way that we look at this is we will do this definitely in somebody who has a curative option, in people with localized disease that may be undergoing chemoembolization who appear to be responding. I think those people maybe you can consider it in. And people who have advanced disease who you're talking about a median survival that's still around a little less than a year and maybe a little bit over a year in the select group with good response, I don't know if you're going to see a great benefit to doing HCV treatment.
I try to be politically correct to my friend Richard Finn, but it seems I'm getting very, very well supported by Amit over here. I personally don't give therapy, and I don't support therapy for HCV when there is patient with metastatic disease, understandably so. But there is a curative intent, and as you noticed, even they're very careful. They will wait 3 months at least before they might apply that therapy. So something really definitely very carefully to think about, not only from the perspective of the patient, but really from the health care risk and benefit and cost per se. With this said,